And thank you for joining me for a brief discussion of egg freezing. This is the 101. Maybe one day we'll do a 102. But this is just kind of meant to give you the basics. Feel free to follow up with me by email or however it's easiest if you have follow-up questions as well. And there'll be a chance to ask any questions you have at the end of the seminar. I'll try to keep things as general as possible. If you have specific questions, I might kind of generalize them in a way that everyone could benefit, but happy to answer any questions you have at the end. The way this is functioning, I don't think I can even tell if you ask questions until the end. So please be patient. And at the end, I'll get to all the questions that were put in. All right. So starting at the beginning, this is sort of the underlying issue of why we freeze eggs, which is that a woman is born with all the eggs that she will ever have, and that number then decreases. In fact, the maximum was before she was even born. As a fetus within the womb, there were about 6 million eggs that were created at that time, and by birth, a lot of those have already been lost, and there's about 1 million eggs that are present within the ovaries at birth. And then by the teenage years, when those eggs actually start to release and become capable of creating a pregnancy, the total number is already down to 400,000. Put my phone on silent in case anything goes on. From that point on, from those 400,000, the number of eggs continues to decrease, about 1,000 on average every month. And then by the time menopause, as I'm sure you all know, that's kind of the time when the number of eggs has been depleted and there's no eggs left. So that's only, sorry, just trying to orient myself to the slides. That's only part of the story. The other issue, and the one where egg freezing becomes really important, is that in addition to the number of eggs being depleted, the so-called quality of those eggs is depleted as well. And that's correlated with age, where inversely correlated, where the quality of the egg, the chance of it being normal, decreases with age. And that's where freezing the eggs really comes in to play. So what is meant by a lower quality of eggs? It can mean a lot of things, certainly, and it clearly is going to impact the chance of an egg leading to a healthy baby. But what is it that really primarily changes within the egg as the woman ages is its ability to keep track of the information that the baby is going to need to develop. So that information is normally stored in volumes. They're called chromosomes. If anyone has a biology background or recalls from high school biology, chromosomes are essentially the volumes of the information needed to make a baby. And there's 2 copies of each chromosome or volume. One copy came from the father and one came from the mother. So every embryo has a copy of the chromosomes from the egg and one from the sperm. This is where it gets tricky, because the egg also starts out with both of those copies, and it then needs to discard exactly one copy of each to make room for the sperm. If that doesn't work right, then you end up with potentially 3 copies of one volume or one chromosome, and that's bad. Or you end up with only one copy, which is a copy the sperm brought in, which is also bad. That would be if the egg accidentally discarded both copies. So the egg has to discard exactly one copy of each chromosome. Otherwise, you cannot have a healthy baby. And that's where age really comes into play. The way that the egg separates these volumes, the one copy of each volume, is something called the spindle apparatus. It tends to make mistakes, and it tends to make more mistakes as it gets older. And remember, the exact same egg has had the exact same machinery within it since the day the woman was born. So you can imagine with time, for various reasons, it will become less efficient and less accurate. So even in ideal situation, a woman who has perfect fertility at a young age, typically only about one out of four eggs is going to get this process right. 3 out of 4 are going to be abnormal, and that's why couples usually don't conceive every single time they try. They might, but the odds are about 1 in 4 for that reason. An abnormal egg will typically lead to an embryo that just doesn't work. Now, as a woman gets older, the odds of that machinery working decrease, the machinery working correctly and getting everything exactly right. So that the odds might be 1 in 4 at age 25, but they're less than 1 in 100 at age 45. And it's kind of a decrease throughout the years in between. So obviously, if we can freeze eggs when they were more likely to get the process right, we're going to have a much better chance of making a healthy baby, and that's where egg freezing it comes into play. So let me get into some of the technical language here because it is in the graph, so I just want to hit on that. An embryo that has a wrong number of copies of each chromosome is called aneuploid, meaning that it has either 0 or 2 from the egg and 1 from the sperm. So it ends up with either 1 copy of a volume, and it can be any of the volumes, any of the chromosomes. If there's only 1 copy of it, that's most likely an embryo that's not going to be able to be viable with certain other than 1 specific chromosome. But most chromosomes, if there's an entire copy missing of that chromosome, there's only 1 instead of 2, that's going to be an embryo that just can't work, either live for a few days. If it's a kind of a severe lack of information, maybe 2 volumes missing, live for a few days, and not even be able to create a pregnancy. So it would never even be detected as a positive pregnancy test, never make a period late, wouldn't even be recognized. Less severe abnormalities along kind of the spectrum would be an embryo that can live for a few weeks. And those would be obviously early pregnancy loss. And that is, in fact, the most common cause of early pregnancy losses, is that there was the wrong number of chromosomes in the egg that embryo came from. And then some of the least severe would be, for example, having 3 copies of chromosome 21. That could make a viable baby, but one with Down syndrome. And only if there is the exact right number of copies of each volume can that make a healthy baby, meaning that only eggs that got that division process perfectly right. So what are the odds that happens? Well, one of the ways we can look at that is on this graph. This graph represents eggs that were already fertilized, became embryos, and were then tested to see which ones are normal. And that's part of the normal process now before we put embryos back in. And that would probably happen with anyone who froze their eggs. And then before they put an embryo in, this kind of testing would be done. So what this shows is what are the chances that embryo is abnormal. And you can see even in the best scenario, there's still about a 30% chance that pregnancy is abnormal. And then from the mid-30s on, the risk that embryo is abnormal increases. And obviously only the normal embryos are ones that we would then be able to use to create a pregnancy. So this is part of the issue. When we freeze eggs at a younger age, it's much more likely that one of those eggs is going to be able to make a normal embryo and therefore a pregnancy. Whereas if we freeze eggs at a later age, it becomes less and less likely, and that's where the challenge comes in. And that's kind of the concept behind freezing eggs, is you want to do it when those chances of abnormality are low, so that at a later age, when natural conception would lead, or using eggs for IVF even at a later age, would lead to a much lower chance of an embryo being normal. All right. So kind of trying to put all this together. What does that mean for the odds of being able to have a baby? So there's two components here, as you've gathered. One is what are the chances for each egg to be normal? And the second part of it, obviously, is how many eggs do you have? Because each egg is an independent chance. So even if it's unlikely for an egg to be normal, if there's a larger number of them, the more you have, it's cumulative. So a low chance for one egg is going to be, if an egg has a 5% chance of being normal, it's going to be 5%. If there's 20 eggs, then the odds are much higher, somewhere around 50%, because any one of those eggs could be normal and make a baby. You only need one to make a baby. So both of those numbers, both of those factors come into play in determining what are the chances that freezing eggs will result in a healthy baby once you get around to using those eggs. And by the way, it doesn't matter how much time lapses in between, it just matters the age when they were frozen and how many were frozen. So how do we use these tables to look at that? How do we try to predict those odds? For example, as you see in the left margin, it gives you the average number of eggs that we can collect at a given age. Important to note, these are averages. There are some patients certainly that might have 3 or 4 times as many, and some that might have a quarter as many. These are just averages. And for any specific woman, the eggs supply, which translates to the number of eggs available for us to freeze in one cycle, can decrease at an earlier age, and these numbers might be lower, or it can stay higher at a later age. And sometimes even at age 41, there might be 15 or 20 eggs available. So there's a lot of individual variation, but these averages hold up pretty well when you look at a population. So it kind of gives you an idea of what to expect. So let's take the example of someone who is under age 35 freezing eggs. On average, we'd expect to get 15 eggs. 15 eggs, if you look at the age under 35 graph, would give you about a 70% chance of live birth of one healthy baby, and also about a 35% chance of 2. And then about a 10% chance of 3 live births from that one group of 15 eggs that typically would come from one cycle of freezing eggs under age 35. Going to kind of the other end of the range we're looking at, just to give you an idea, and obviously there's everything in between at the different ages in between, but just to give you an idea how this changes, going to the other end of the range that we're looking at age 42, we might expect to have 7 eggs frozen, and because each egg is also less likely to succeed, that ends up giving about a 15% chance of a single live birth. So in that situation, you hope that someone obviously would have a number of eggs that's above average for her age. And if not, then you might want to look at maybe doing more than one cycle of freezing eggs with an expectation of 7 for each cycle. Doing 2 cycles of freezing eggs would bring it up to kind of what we would have expected with one cycle at age 30, about 15 eggs. But because each egg at that age has a lower chance of working, that gives about a 30% chance of a live birth as opposed to the 70% at a younger age. So that kind of gives you an idea of how it changes with age and why we are going to do better if a woman comes to us younger to freeze eggs, but still have a chance of making it work at an older age, albeit typically you'd want to do more cycles of collecting eggs at that age to try to get a reasonable chance. So what's this I was talking about in terms of individual variation? Those averages are not going to be particularly helpful for you specifically because everyone's different. And again, egg supply can start to decrease at either a younger age or it can hold out till a later age. And so you really have to look at the individual to be able to figure out how many eggs can you expect to get during the egg freezing process in one cycle. And so how do we determine that? This is called ovarian reserve testing. The number of eggs available is the technical name for it is ovarian reserve. So there's two different ways we look at that. And let's just briefly go over what those are. AFC and AMH. So what are those? AFC stands for antral follicle count. And that is very simply counting the number of antral follicles seen within the ovary. This is a sonogram image. Sonogram is produced with sound waves, so there's no radiation. And the sound waves bounce off the ovary in different ways, showing you where there's pockets of fluid. So these little black circles are pockets of fluid. We know that the ovary tends to form these pockets around an early egg that starts to become available. And these are the eggs that we could expect to be able to collect during one cycle. Obviously, these aren't all the eggs in the ovary. In an ovary that looks like this, I'd expect that there's probably 100,000 eggs, but most of them don't have little fluid pockets around them because they're not ready to develop yet. But this gives you an idea because it's proportional. When there's a large number in the underlying supply, then there's going to be a larger number that become available each cycle. And these are the ones that are becoming available. So to do an antral follicle count, I would do the sonogram and simply count these. There's about 10 of these in this ovary, and there might be 10 in the other one. So that would give you an idea that there might be 20 eggs available for an egg-free cycle. That's not a one-to-one direct relationship. It's not going to be an exact indication, but it puts you in the ballpark of kind of getting an idea of what's the potential. If everything goes perfectly, how many eggs might we be able to collect and freeze in one cycle? So that's one way of measuring it. I really like this approach because it allows me to give the patient an answer at their very first visit. And it's something that I do at every single first visit to kind of get a snapshot of, okay, where are we with egg supply right now? Another way of looking at that is to measure the hormones these are producing. Those little circles within the ovary correspond to graphic representation here of the follicle. As I mentioned, that's the fluid pocket. That's what shows up black on ultrasound. Fluid's always black. And within that is the egg. It's not really as big as it's made in this picture, but it's just, I guess, so it's easier to see. Within that is an immature egg. And each of these little pools of fluid around the egg has helper cells within it called granulosa cells, and those make this hormone called AMH, which stands for anti-Müllerian hormone. And so when you measure that in the blood, even a blood draw from the arm, that's going to tell you how many of these little eggs that are becoming available are present. Basically the same information we had by counting how many of them we saw in the ovary. Because each of these are pumping out AMH, we can determine approximately how many there are by looking at the AMH level. It's a step removed, probably a little less accurate in my mind, but some doctors like to really rely on this, and it can be very useful for a lot of things. What I don't like about this is it takes at least a few days to come back, so it's not something I can discuss with a patient at their first visit. So not quite as useful from that standpoint. So important to note, both of these methods, an AFC, which is antral follicle count, or an AMH, anti-Müllerian hormone, is fairly good at giving you a snapshot in time. It is worthless at predicting how that might change over time. And I've seen it sometimes a low level, surprisingly low level, even at age 32, stays exactly the same for years, and sometimes decreases drastically over 6 months. So none of this can unfortunately give us any way of predicting how quickly it changes. We're still working on figuring out how to do that, because that's really kind of the what we'd all like to be able to tell a patient is, you need to freeze eggs because this is going to go down soon, or this is going to stay the same for a long time. Don't worry about it. And we can't do that from this information. We can just give a snapshot in time. Obviously, if the numbers are good, then there's further to go before things become challenging. And so that does give you some indication that there's a little less urgency. but certainly not a guarantee, because sometimes it can start to change quickly in a very unexpected way and for no explainable reason. Let's see, moving on, the next thing I wanted to discuss is how is it that we get these early eggs that you saw in the sonogram to then, so how is it that we get these early eggs that are these circles in the ovary to then become mature eggs so that we can actually collect them? We can't use immature eggs. They're not going to be able to be fertilized. They can't make a pregnancy. So these need to become mature. The way that normally naturally happens is through hormones that the pituitary gland sends to the ovary. Pituitary gland's in the brain. It sends these hormones through the bloodstream, through the whole body, and eventually they end up at the ovary. And primarily FSH is a hormone that causes these little circles to mature, and they grow and become larger pools of water that have more likely to have a mature egg within them. What naturally happens is that the pituitary gland is very good at sensing when one of these starts to develop, and then it shuts down the extra FSH so that only that one egg develops and the other eggs don't have a chance. And that's important to prevent multiple pregnancy, obviously. And so that's kind of something the body's developed, a feedback mechanism, so the pituitary gland doesn't allow extra eggs to develop. Of course, that's terrible for what we're doing because we want all of these to develop and be able to collect all of them at a mature stage. So the way we do that is we add extra FSH, supplemental. So this is the same hormone your body makes, but it's given through an injection. The levels aren't so different from what you might naturally see in a body, but rather than just that short period of time for one egg to develop, we're going to extend the amount of time that higher level of FSH is available so that all of these eggs have a chance to develop. It's, I think, really important to note that what we're doing here is stimulating these eggs that were available. If they weren't stimulated during the process to prepare for egg freezing, they would have degenerated and died. What we're doing can in no way impact the tens of thousands of eggs that are present within the ovarian tissue that are inert. They're not ready to develop. They can't respond to the FSH. They don't do anything. And that's great because that means that they'll still be available the next month or the month after, whenever they decide to become available. So egg freezing and the collection of the eggs is simply I like to call it a search and rescue mission. We're rescuing the eggs that would have degenerated that month. We are in no way affecting the future supply of eggs. That the next month, the new eggs available will be exactly the same again, or there's some variation month to month, but it can be up or down the next month a little bit. But on average, it's going to be the same as it was before we did the egg collection. We're not in any way impacting the eggs, so that'll be available in the future. So how does this kind of play out in terms of the day-to-day experience for a woman undergoing egg freezing? Typically, and it's not necessary, we actually have developed technology that we can start this at any point in the cycle, but we typically start it with the beginning of the period, just because that's kind of following the natural flow of things. That's when eggs normally start to develop. So you would come in on about day 2 or 3 of the period. We'd check everything, make sure everything's good to go with a sonogram to make sure there's no cysts in the ovary, nothing's going to interfere. We check the blood test, and then we'll have you start those hormone supplements. They are by injection, and those are taken every day until the eggs are ready. During that time, I typically have patients come back every 3 days or so. Sometimes if things are kind of going very predictably or very early in the process, it's every 4 days. Sometimes if things are unpredictable, I need to change the dose and see how the ovary responded to that dose change. I might have a patient come back in 2 days or even the next day. So it's a little unpredictable as to how frequently we need to be seeing the patients, but typically it's about every 3 days. to, we're realistic. We don't expect you to take 2 weeks off of work to come in when we need you. So we do these early in the morning. We'll start at 6:30 a.m. so that patients can kind of get in, get the tests done that we need to evaluate how the ovaries are responding, making the adjustments we need to make, and they can get on with their day. Total, typically about 4 or 5 visits through one cycle. One cycle lasts about 2 weeks. 12 days of that is the injections, and then you get a day off. And then 2 days after the last injection is when we collect the eggs. So how is the collection of eggs done? It is, most importantly, done under IV sedation. The patient is completely asleep, does not feel any of this. Most patients actually tell me they had a really great nap. It takes typically about 10 to 15 minutes to do. It's done with an ultrasound that is in the top of the vagina, visualizing the ovary. Now, these pictures are kind of made to kind of everything very spread out to make it obvious where things are. This is the uterus, the fallopian tube, the ovary. In reality, these aren't stiff. These are very soft. Oh, my battery's running out. Let me just plug in my computer. Sorry. These are typically very very soft connections that the ovary has, and they're typically hanging down right here. So that makes it really easy to just place the needle through the vaginal wall into the ovary, really avoiding any other organs that might be in the area. And we do it all by watching with a sonogram. On the sonogram, I can see where the ovary is, I can see where the needle is, and that really maximizes the safety of this procedure. And the needle passes into that little fluid pocket. At this point, the fluid pockets are larger because they enlarge as the egg matures. And then suction is applied, and the fluid's pulled out, and the egg is pulled out along with the fluid. And where does it go? So we then, how do I get to the next slide? We then collect the fluid through this needle and into a little tube. And the embryologist then evaluates these eggs under a microscope, makes sure they're mature. Sometimes some of the eggs we collect haven't finished maturing. Those we then will give them the right hormones in the lab to help them mature and give them another day in the incubator. And sometimes they'll finish the process, and then they can be frozen along with their sibling eggs. Sometimes they don't finish the process, and there's no point freezing them because those can't be used. But the majority typically are going to be mature and are going to be frozen. So this is an important point. We freeze mature eggs. Those eggs have already undergone the process where they've divided up the chromosomes. So the chance that that egg is going to be normal has very much to do with the age of the woman. Probably the only important factor is the age of the woman when that egg was collected, because that apparatus, the spindle apparatus, has to divide up those chromosomes correctly, discarding one copy of each to make room for the sperm eventually. But that discarding of one copy of each happens just before we collect the egg, so that by the time we've collected it and we're freezing it, that part is done. And how well it was done is dictated by the age at which we did this process. How long the eggs are frozen has no bearing on their quality, will not in any way affect their success or the chance of an embryo being normal. They could be frozen for a month, or they could be frozen for 30 years. It won't make any difference. The limiting factor, this is here, this is the freezer where they're actually kept. And it's obviously a setup with many backup systems, many alarms, very safe. Power outage we're prepared for. There's backup generators, and obviously a great deal of safety in terms of restricted access and so on. The limiting factor to how long the eggs can wait until they're used really ends up being very simply the woman's health. is she healthy enough to carry a pregnancy? Someone who is healthy, especially if they exercise, typically into the mid-50s would be acceptable. Whereas if there's other health factors, then that may play a role. But that's really the determinant of how long the eggs can stay frozen before they're used. Otherwise, there's no limiting factor in terms of them being frozen. We're keeping them at minus 200 degrees Celsius, and at that temperature, all activity within the egg stops, and time essentially has stopped for them. So what happens when the eggs are thawed? Here's a photo of an egg after it's been thawed under the microscope. This is simply a holding it in place. And this is a needle that's placing a sperm into the egg. And then the sperm and egg combine to make an embryo. The embryo starts out with one cell and then divides and makes two, and divides again and makes four, and divides again and divides again. And that process we allow to go on for about 5 days. When it's reached the next stage called the blastocyst, at that point, there are ample cells so that we can take a few off the outside, the part that'll eventually become the placenta, without hurting the embryo. And those cells are then sent to a lab for genetic analysis so we can determine what are the number of chromosomes. Is there exactly 2 copies of each chromosome? That can be, and that can tell us, did this embryo come from a normal egg? So that's actually when we find out, are any of the eggs that we had collected maybe 10 years earlier, are any of those eggs, were any of them normal? And that way we can completely prevent things like Down syndrome, and also miscarriage that's caused by the wrong number of chromosomes. Those things can be almost completely eliminated. Nothing in medicine is 100%, but it's pretty darn close in this case. All right, so I think that's all I wanted to say. Let me see if I can figure out now how to look at getting questions. Bear with me for a minute. I'm sorry. Where's my escape button? Okay. So let me see if there are any. Okay. I don't see any questions. So this would be the time to submit your questions if you have any. And if you don't, I can discuss. Let me see if I can get my screen back. Give you a chance to enter any questions you have. Let's see. I don't see any questions yet, but I think they'll pop up. If you have any, in the meantime, I'm going to share my screen. Okay, there's questions coming in. So I'm not going to share my screen because then I can't see the question. Sorry. So if you have questions, please put them into the Q&A box. I think there's a chat which is disabled, so don't use that. But if you put them in the Q&A box, I'll get them that way. So here we go. First question. Yeah, great one. I get this question frequently. Obviously, very understandable to be concerned. The question is, are there any side effects or long-term consequences of taking the drugs? So most of what we're using are hormone supplements. They're hormones that are naturally in the body as opposed to medications. And there's been obviously a lot of research done on this. The main concern has stemmed in the past from finding that women who have undergone IVF might have, on average, had a higher risk of certain problems, ovarian cancer specifically, than women in the general population. What was determined when that was evaluated and sort of parsed out is that there is a higher risk of ovarian cancer that comes with infertility in general. And obviously, women who had IVF are women who have infertility. So, at least in the past, I mean, now it's being done for many other reasons, obviously, but back when these studies were done, so that the increased risk of ovarian cancer actually seemed to stem from whatever was causing the infertility, as well as from lack of pregnancy. This is, back when IVF was not as successful. A lot of the patients ended up, unfortunately, not being pregnant, and never having a pregnancy creates an increased risk of ovarian cancer. Meaning, might make more sense if I say it the other way around. Pregnancy is protective against ovarian cancer. So infertility patients were more likely to have it for that reason as well. And so when you actually parse out and compare women who went through IVF versus women with infertility who didn't go through IVF, that risk disappears. So long-term studies have shown pretty conclusively there's no increased risk of invasive ovarian cancer. There's no increased risk of breast cancer with IVF. There is a small increased risk, a very small increase in risk of borderline tumors. These are cysts that form in the ovary that, if gone untreated over many years, have a higher risk of developing cancer. But of course, if they're treated and removed, then that's not a concern. And the risk of those forming was very low. I think it was less than 1%, even in kind of the long-term follow-up. So there's no specific long-term consequences of concern. And then in terms of side effects, the newer medications that we use now typically don't cause side effects. This is something that was more of an issue with the medications that were used 10 years ago, where women develop something called ovarian hyperstimulation syndrome fairly frequently from having eggs stimulated. Today's medications prevent that. Something I used to see every week in back in like 2000, now I can tell you I haven't seen a single case in 5 years. So the current medications essentially eliminated any of those severe side effects that would have involved being admitted to the hospital or need IV fluid or anything like that. The side effect that patients do have is completely dependent on how many eggs develop and are available to be collected. So meaning if the cycle goes really well and there's over 20 eggs developing, you're going to feel the enlargement of the ovaries within the belly. And that bloating is something that would be there for about a week before the egg retrieval, and then kind of happens again a little bit after the egg retrieval as the pockets where those eggs developed refill. So it takes about a week to go away. It can just be a bit of abdominal fullness, bloating, feeling. But again, those are only in cases where this goes really well. Not on average, not something that women notice. I hope that answered the question. Let's see. Next question. Do you have to get all your eggs tested? So there's actually no way that we have of testing eggs. The testing is done on the embryos that result from those eggs. And answer is it's not required. A lot of patients choose to do that. A lot of whether they want to do that depends on their age when the eggs were frozen. Of course, the older they were when the eggs were frozen, then the higher is the risk that there could be Down syndrome in that embryo. And so that is an impetus for testing. Also, the higher risk that embryo could result in a miscarriage, which can be an emotionally very difficult thing to go through. So typically women who were older when they had their eggs frozen will choose to have the genetic testing done on the embryo. And these days, even most couples that were younger when they were frozen choose to do that. But it's certainly not necessary. You could skip it. I hope that answers your question. Feel free to re-enter questions with different wording if I somehow missed your intention. Next question. How many cycles would you recommend for a 38-year-old woman? That's a great question. And the answer is it depends. Every 38-year-old is going to be different in terms of how many eggs we actually collect. And how I approach the question of how many cycles to do is to start out by asking, how many children do you expect to result from these eggs? 1, 2, 3. And then secondly, what percent chance are you comfortable with of reaching that goal? So, typical answer to that is, well, I want to have at least one live birth, and I want at least an 80% chance of that happening. And how many eggs we need to achieve that does depend on age. But also depends on how many eggs were collected during that egg freezing cycle. So I can't specifically say for someone who's 38 without knowing how many eggs we were able to collect. Let me see if I can get back to sharing this graph. No, I think it's going to be too difficult probably. But I can tell you the average that we get at age 38 is 10, but the range is huge. We sometimes get 2 and sometimes get 30 or 40 eggs at age 38. So if a woman has the average of 10 eggs, that would only give about a 35% chance. I would recommend, if you want a 70% chance, that you plan on at least 2 cycles of freezing eggs. That would give you a 70% chance of a live birth at age 38, if you get the average number of 10. But you might get 20 eggs in one cycle of freezing and decide you're done at that point. So it really depends on how it goes. It's a question that's best answered after the egg collection is done, and I know how many eggs there were. Let's see. Next question. Can you tell if an embryo is stronger than the others? So there's 2 different ways of assessing that. There's the genetic approach, which involves testing and finding out if the chromosomes are normal, and that is kind of the most accurate, best way of predicting is an embryo going to work. That's going to by far be the best predictor. And that does help you kind of select which embryo to put in so that you're more likely to get a success. Without doing the genetic testing, you can still evaluate the embryos by their appearance. How even do the cells look? How many cells are there? How quickly did the embryo develop? All those things can help predict. And we have a grading system that we use to then actually grade the embryo based on those characteristics and give you indicator of which embryo is more likely to work and what that difference is. It reminded me, one of the things I forgot to mention, which some people want to know and others really want us to keep secret and not tell them at all, along with the genetic testing of the embryos does come the gender. And some people have a preference, and that can be done if you have at least one embryo of each gender. And then other couples really want to be surprised, and then we'll keep that secret if they ask us to. Next question. Is there a need to shop around for facilities to do this procedure? I would say you at least want to know they have a significant amount of experience doing this. They've been doing it long enough to see the results. Part of the problem with egg freezing is programs that are new to it may be freezing eggs, but if no one's come back to use those eggs yet, they don't really have a track record, and you can't really get an idea of what's going to happen once you're ready to use those eggs. Let's see. Next question. When the eggs are being tested, can some of them be destroyed? I assume you mean unintentionally destroyed. Um, the and I again want to return to just I guess it's semantics, but just to be make sure we're talking about the same thing. It's not eggs that are tested; it's the embryos. The eggs cannot be tested. When the embryos are tested, and I guess I can interpret this question two different ways. I'll answer it both ways. Can they be harmed accidentally? Um, it it is unusual, less than 5%. Um, I would say I see it, just kind of estimating what I've seen, maybe 1 in 100 embryos that are harmed by the biopsy procedure, where we take a few cells out of the outside. Um, Typically, in the past, it's been closer to 5%. It's about the highest I've heard. So at least 95% chance of the embryo um, doing well. And then I guess the other way to interpret the question is, can the embryos be destroyed? Meaning, if you don't like the results, and certainly if the embryo is abnormal, it's going to create a, we know it's not going to work or create a miscarriage, and absolutely those embryos would be discarded. Um, let's see, next question. Or if actually the other part of that is if you're done, completed your family, embryos can be discarded or donated. It's up to you. Once the eggs have been used and you've been able to have all the children you want, you can certainly have that option. And the next question: are there risks in the thawing process? Well, that's a really interesting question. Um, it again, it's unusual, but there can be about a 5% rate of loss of the eggs. And you see that when you thaw the eggs, but probably the damage happened when they were frozen. The freezing is the part where the eggs potentially are more likely, potentially can be harmed. So really, you want to make sure the egg freezing is done right. And the best way to do that is with something called vitrification, which is a very rapid freezing of the eggs. It is somewhat user dependent, so you want it done at a facility that has a lot of experience doing that. And that type of rapid freezing gives you a 95% survival rate of eggs typically. So that really minimizes the risk of eggs being hurt through the freezing and thawing process. All right, next question. I love it. They're pouring in. I'll get to all of them, I promise. Is there an estimate number of how much this will cost for a person whose insurance does not cover this? I don't know. I'm not sure. You'd have to speak to our billing department. It's not something that I have a lot of knowledge of. Typically, insurance hasn't been covering it, but some have started to, so it's a good idea to check with your insurance. I think it's, yeah, I don't know. I'd just be giving a wild guess. I'm not really sure. But if you call the office, you can ask to speak to the billing staff, and they can give you the actual prices. Probably somewhere in the neighborhood of $10,000. That's just a wild guess. I'm not really sure. I've heard, and then next question. I've heard of a luteal phase stimulation using estrase pills prior to the first flow of the month. Are there disadvantages and advantages of luteal stimulation? Okay, so I think what you're referring to is not luteal stimulation, but estrogen priming, where estrogen pills are taken before the stimulation begins. There's a couple of different ways of achieving the goal that this has. Another way of doing it is with birth control pills. So they're kind of two different approaches, the same thing. And ultimately, the goal of this, either taking estrogen pills or taking birth control pills before you start the stimulation of the eggs, they both have the same goal, which is to help the ovaries rest, meaning to avoid any of the follicles from starting to develop before the others. You kind of want them, weird analogy, bear with me, but you kind of want them sort of lining up like like I guess Olympics on the mind, like runners at the starting line, and then have all the eggs start at the same time, so they're all develop at the same time. If you have one or two eggs that develop early and some of the others aren't developed yet, do you collect? Then you're stuck deciding: do you collect just those one or two eggs, or let those get over mature and possibly be lost, and wait for other eggs to develop? And you're not going to get as ideal of a situation. The ideal is for all the eggs to develop together as a group, and to do that, you kind of need them lining up on the starting line at the same time. And one way of achieving that is to prevent any stimulation to those eggs until you're ready to give them the full stimulation all at the same time. And a way to prevent the brain from stimulating the eggs is to make it think that there's an egg developing already. And if the brain thinks that, then it won't send any stimulation, and the eggs just rest and kind of get ready to go and kind of line up there. And that can be achieved with estrogen, because estrogen tricks the brain into thinking that there's an egg already developing, so it won't stimulate. And it can be done with birth control pills, sort of in the same way. The estrogen is probably a bit more of a gentler way of doing that, potentially also less effective though. So I think that's what you were referring to, is taking estradiol pills in the luteal phase. You use the term luteal phase stimulation, which typically means something different. That means not starting the process at the beginning of a period, but actually starting everything we talked about after ovulation. And that can be done as well if, for whatever scheduling reasons that works better, that can be done too. No specific advantages or disadvantages of doing it that way. Seems to work okay. I guess the main disadvantage is there's less experience with that approach. Right, next question. Is egg freezing still an option if the woman has a blocked fallopian tube? It's an even better option in that situation. So yes, absolutely. The fallopian tubes do not come into play whatsoever in collecting the eggs. The needle goes from the vagina directly to the ovary. Fallopian tubes play no role. And in fact, they're completely bypassed then when we put the embryo back in, because we put the embryo right back in the uterus. So with blocked tubes, you have a pretty good idea you'll probably need IVF to conceive, and how likely that IVF is going to be to work entirely depends on the quality of the eggs. So that's where egg freezing is really helpful, because you know that way when it comes time to do IVF, you're going to be doing it with better quality eggs because they were frozen earlier in life. Next question. Is weight gain a side effect? Great question. So there typically no, but there can be some small amount of temporary weight gain, typically just a few pounds, and it all goes away about a week after the egg retrieval is completed. Egg retrieval is a process where we collect the eggs to freeze them. So about a week after the process is completed, it reverses and goes away. It's partially due to the ovaries enlarging, because as the eggs mature, they form large fluid pockets. And instead of having one of these mature eggs with a large fluid pocket, you might have 10 or 20. So that causes some weight gain, potentially a very small amount. And then also the few days after the eggs are collected, the body's making more progesterone, which is a hormone that causes water retention. And that can cause for typically about a week. And it almost always goes away a week later. All right, let's see. Next question. Excuse me. Do you freeze sperm before injecting to frozen eggs? You can. No reason you need to. If for some reason scheduling wise, you need to do this when the man producing the sperm is going to be out of town, that can be done. Doesn't really matter either way. If they're there, then we'd use fresh sperm. Primarily, frozen sperm is used to inject frozen eggs. If you're using donated sperm, that's always going to be frozen, and that can be done with anonymous donor sperm that you can choose from a sperm bank. So it can be with frozen sperm. Doesn't need to be. Doesn't really make a difference. Next question. Yeah, it's a great question. So what can I do at home to best optimize the egg freezing process? So let me start with the things that are proven and then go with some of the things that are being looked at but have yet to be proven, and may turn out to be useless. So in the first category, what's been proven? Weight, being overweight has a negative impact on being able to collect eggs for several reasons. One is the injections don't work as well. Second is that the collection of eggs tends to be more technically difficult. Um, so being significantly overweight is something that can negatively impact the process. And so in that situation, weight loss would be helpful. Someone who is uh, 10, 20% overweight, over their ideal weight, probably not going to be an issue. But someone who's 30 to 50% or 100% over their ideal weight, that's where it starts to be an issue. And some weight loss prior to egg freezing would definitely help. But there is a trade-off, because a much bigger factor is age. And so depending on how much time might be taken for that weight loss, typically it ends up not being worthwhile, because it can, potentially be a difficult process that can take months or years for weight loss. And so during that time, age is going to be working against you potentially more rapidly than weight loss is helping. So in general, not a worthwhile trade-off, especially someone who's not far overweight. Other things that have been proven to help, avoid nicotine. Certainly with cigarettes, there's a negative impact on egg quality. Vaping, we don't know, but probably. So even hookah use, anything like that, any kind of nicotine, tar, tobacco, you should avoid. Those have been proven to have a negative impact on eggs. Other proven things that have a negative impact, the obvious stuff, radiation, chemotherapy, things that probably hopefully aren't playing a role, but certainly things that we consider in someone who is undergoing cancer treatment. We want to freeze eggs before they would be exposed to either chemotherapy or radiation because of negative impacts. And then kind of moving on to the things that aren't proven, but are being looked at and are interesting to consider. There's a supplement called CoQ10, which some initial research has shown could improve egg quality. Other research did not back that up. So the jury's still out, but it's something that's pretty easy to get over the counter, and a lot of people take it for heart health as well. So that's something that, if I was freezing eggs, yeah, I probably would be taking CoQ10, just in case it helps. And then there's herbal supplements, some which can potentially even have a negative impact. A lot of herbal supplements are hormonally active in unpredictable ways. So you want to be careful with those. And unfortunately, not enough research done on herbal supplements to really know which ones could cause problems. Next question. Does insulin resistance or PCOS have an impact on success rates or considerations associated with egg freezing? So this also is in the realm of not being clearly proven. But I think all of us that work with patients freezing eggs have on our own noticed that there can be a negative impact of PCOS. Correcting the insulin resistance hasn't been shown to improve that. If I would say in half of women, PCOS can be related to increased weight, and in those cases, losing weight clearly is going to have a benefit. But half of women with PCOS have a normal weight, and in those cases, weight loss would not be of benefit. Next question. This question kind of goes along with one we talked about, what can be done to improve the outcome of egg freezing. That kind of, I think I already answered. And this is the last one. Oh, no, okay, now I have two more. Great. One more question. Okay, will an endocervical polyp removal affect the uterus for implanting fertilized embryos, or impact successful pregnancy? No, typically not. Removing an endocervical polyp typically does not impact fertility or implanting embryos in the uterus. Generally not a concern. And then someone asked if I've heard of True Neogen. I haven't. Sorry, I'm not familiar with that. And now I'm curious. I'm going to write it down and look into that. I've not heard what that is. Sounds like a supplement. Maybe I'm not familiar with. I'm sorry, I can't give you a good answer to that question. So I think we've gone over the time. I'm sorry. To kind of wrap up, trying to think if there were any other points that we needed to go over. I think that was it. So I really enjoyed this. Thank you, everyone, for your awesome questions. Thank you for the segue. I just got a question. Is it possible to have a copy of this recording shared with us? I think parts of it do end up getting posted. I don't know and don't have control over that. If you call the office, I think ask for the marketing department. They might be able to figure that out for you. I wanted to just also share with you the information for getting in touch with us should you want to schedule a consult. The other question that didn't come up, and I'm really surprised it didn't, I probably should have brought it up, is when is the right time to freeze eggs? At what age? Trying to share my screen here. Let me see, just so you have all the information to get in touch. Slideshow. Here we go. Yeah, here we go. Okay. So, a question that I often get in regards to egg freezing: when should this be done? There's no perfect answer. Obviously, earlier is better. The trade-off being that if you then meet somebody a week later, end up getting married and having a family and never needing those eggs, and you were probably too young when you froze them and didn't end up needing to. So that's really the only trade-off. But the other consideration is how risk averse are you? Kind of the underlying problem with giving an answer to what age should you be at when you freeze eggs is that not all women lose egg supply at the same rate. So I've definitely had patients who are 30 years old that have an egg supply I would have expected at 45. And then patients that are 40 that have an egg supply I would have expected at 25. So it's really hard to give a good answer to this other than how risk averse the woman is. If you want to be prepared for the risk that egg supply could decrease early, then I'd recommend freezing eggs at age 28. At that age, it is a very low chance that egg supply would have started to decrease. And so egg freezing would still work very well. But on the other hand, someone who is not risk averse is willing to sort of take that risk and gamble that they're more likely to be average. If you turn out to be average, then probably 34 or 35 is a good age to freeze eggs. Again, unfortunately, there's just no way to know if you're going to be average or whether egg supply will start to decrease early. So that's where it comes into play to consider how risk averse are you. And in terms of the length of time the eggs are frozen, that makes no difference. So from that standpoint, it's better to do it the younger you are, because the more likely the eggs are to be normal, and the more eggs you can retrieve in one cycle. All right, so I think that is it. Let me see if any other questions came up in the meantime in the Q&A box, if I can find it. Sorry, kind of juggling things on my screen. Additionally, I wanted to mention it can be very useful to simply schedule a consultation. Typically, these are covered by insurance, to have a consultation for fertility testing, to find out where are you in terms of egg supply, to get a snapshot in time. I can't predict the future, but it can give you a lot of information. I think it can be very empowering to know where your egg supply is at any specific point in time. And it's something that can be answered in one consultation by doing that sonogram. So that's a common reason I see patients. I can kind of give you some guidance as to how urgently you should be thinking about the concept of freezing eggs. And at least that evaluation is typically covered by insurance. So this is a phone number to call. I think I'm sharing the screen here with a phone number. Sorry, I'm having trouble. Let's see. Okay. Here. All right. I got the phone number up. Okay. So here's the phone number. Feel free to schedule a consultation, even just to evaluate the egg supply and give you an idea of where things are at, and whether there's any urgency at this point in time. This was a lot of fun. I look forward to doing another seminar, and hope you all got useful information out of it. And feel free to either send me questions or schedule an appointment. I'm going to end the seminar because we're way over time. Have a good evening, everyone. Oh, I'm getting more questions. Okay, I don't think I ended it yet. I actually just saw a couple more questions pop up. How do you tell if a woman at age 30 has the egg supply typical for age 45? Really only by those two tests that we discussed, the antral follicle count, which is done by sonogram, and the AMH level, which is a blood test. Those are really the only ways to know. Another question, if you've had a recent myomectomy, will that affect egg count? No, it shouldn't. No, typically that will not affect egg count. Sometimes surgery on the ovaries can affect the supply of eggs available, depending on how that surgery was done. And so I always warn people who are having a cyst removed or something like that to potentially consider freezing eggs first, because that can have a negative impact on egg supply. The surgery on the ovary itself, potentially. Ovarian tissue can be destroyed during the process. Another question came in. Does 0.6 mean a low supply? Sounds like that's an AMH result. A normal AMH is above 1. 0.6 is lower than normal, but certainly a range where there's still options. All right, I hope that answers everyone's question. Let me go through the list. I think I hit them all. Can it change? Can the AMH level change? It can bounce around. That may have to do with the accuracy of the lab. Sometimes you can test the same blood a few times and get different results just because the lab result is not that consistent. It's a finicky assay. It's an assay that's also not well standardized. So if you send the same blood test to different labs, you'll get different numbers. So it's not unusual for a patient to end up with several different AMH numbers and not be sure which one's correct. And the answer is probably somewhere in the middle. If you're asking, can it change because of a real change in the egg supply? Typically not in a few weeks, but in a few months, it can. That is typically something that only goes down with time. I wouldn't expect it to increase on its own. Other than, again, different lab error, you can get a level that's higher, but that's not reflective of a real improvement, just that maybe the initial lab test was wrong, but the real underlying supply of eggs does not increase, it only goes down. Can the egg supply be changed by lifestyle? Not the egg supply itself. Other than the lifestyle change would be to avoid nicotine, tar, tobacco, things like that. All right. All right. Thank you, everyone. Have a good evening.